Hi, my name is Camber Giberson, and I'm completing my fourth and final Case Connections presentation for medical biochemistry. I'll begin with case number 2 from Case Connections 4. And I will start by reading this presentation of this case and then reviewing my response. So, in case number 2, a 4-day-old infant is being followed in the clinic. Her birth weight is 5.9 pounds. She had a normal pregnancy and birth. Results from newborn screening demonstrated a phenylalanine level of 6.6 milligrams per deciliter, and the normal range is 1 to 2. A presumptive diagnosis of PKU was made, and additional samples were obtained for further analysis. Parents deny a family history. First question: as a consequence of this presentation, which amino acid may become essential? Well, the primary presentation of PKU presents an inability to convert phenylalanine to tyrosine, which is essential for many metabolic processes in the body. So tyrosine would become essential as the body is unable to synthesize this amino acid. Phenylalanine dietary restriction therapy was initiated at 14 days of age with good response of plasma phenylalanine levels that drop to within normal range. What are the potential causes of this presentation of PKU? So, the most common cause of PKU is due to a deficiency in the activity of phenylalanine hydroxylase, and this results in type 1 PKU. However, defects in dihydrobiopterin reductase can manifest as type 2 or 3 PKU, while defects in dihydrobiopterin biosynthesis result in type 4 or 5 PKU. So, given that the recommended low phenylalanine diet was clinically significant for this patient, I would infer that this patient has type 1 PKU. So, question 3, we will be analyzing the graph presented in this case. And this is the BH4 loading test. So, during this test, tablets of synthetic cofactor were dissolved in 20 ml of water in dim light and administered to the patients at least 30 minutes before the meal. Blood was drawn before and 4 to 8 hours after. Phenylalanine levels were determined. Summarize the results from patients A and B. So looking at this graph, we can see that patient A experienced an increase in blood phenylalanine levels after administration of cofactor. And this is in pretty stark contrast to patient B, who experienced a significant drop in phenylalanine levels following administration of cofactor. So I want to talk a little bit more about the presentation and the metabolic significance of PKU. So patients who have PKU will likely present with higher than normal phenylalanine levels in the blood. And a successful treatment of this disorder should result in a decrease of phenylalanine levels in the blood, as a proper treatment of this order should result in phenylalanine being converted to tyrosine and proceeding down the proper metabolic pathway. So, patient B, we see, experienced a significant drop in phenylalanine levels following administration of cofactor BH4. So, we can infer here that patient B's PKU was due in part at least, to a deficiency in BH4. So administration of BH4 in this case seemed to be extremely efficient in decreasing blood phenylalanine levels and in treating this patient's PKU. And this is in contrast to patient A, that not only was this an ineffective treatment, but it actually led to an increase in blood phenylalanine levels. So we can infer that patient A's PKU was not due to a deficiency in BH4. And we would need more testing and information to determine precisely whether patient A has type 1, 2 or 3, or 4 or 5 PKU. But again, the most common presentation of PKU is type 1. So now I will move on to case 3. Case 3, where a 47-year-old man presents with severe pain in his right great toe, unable to bear weight, with no apparent trauma. The pain started last night and continued to increase in severity. Based on his physical exam and lab findings, he was diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. Plasma urate levels were elevated in this patient, while urinary uric acid levels were average. What is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent with the data, or what additional information may be needed to decide the root cause. So I believe the answer is pretty obvious here, and I believe the correct choice is the overproduction of purines. The overproduction of purines would lead to an increase in uric acid in the body, and if this is consistent and sustained, this would lead to the presentation of gout. I do not believe the correct answer is 2, because a decreased salvage of purines would lead to a decreased production. And this would not increase urinary uric acid levels or plasma urate levels in the blood. And lastly, if 3 was correct, if decreased urinary excretion of uric acid, we would likely see a way lower level of urinary uric acid in this individual. So that's why I do not believe it is option 3. Now, after further discussion with this patient, he tells you he recently switched from diet to regular soda because he read that the fake sugar diet soda was bad for him. He drinks about 4 to 5 liters of soda a day, and the primary sugar in most of these is high fructose corn syrup. What is the potential impact of this dietary modification on the presentation of gout? So, 4 to 5 liters of soda is a very large amount of sugar to be ingesting every day. And this is almost tenfold what the daily recommended sugar intake is. So, and given that he is mainly ingesting fructose and not sucrose, fructose is very easily and readily converted to intermediates that can be used in metabolism, and as glucose is metabolized, purines are released. So the high level of purines and or the high level of fructose in the body that is leading to the release of purines is also leading to an increase of the formation of uric acid in the blood. So again, the sustained sugar intake, the sustained increase in uric acid in the blood would be consistent with the formation of gout. And especially that we can note that his symptoms started shortly after switching from diet to regular soda, this patient was likely already at a predisposition for gout, and the drastic increase in sugar intake caused an increase in symptoms and a presentation of symptoms to begin with. That is all for my case connection presentation, and thank you for watching. Bye.